Today, we're going to go ahead and talk about the patient who presents with vaginal bleeding. Patients presenting with vaginal bleeding can be some of the sickest patients in the emergency department. With that said, they can also be some of the fastest dispos. Here's our approach to patients who present with a chief complaint of vaginal bleeding. Like all chief complaints, the first thing we're going to do is to develop a critical differential diagnosis. Now, the most important one is ectopic pregnancy. The next one would be a vaginal laceration or any type of vaginal trauma. Dysfunctional uterine bleeding or fibroids. An important one to never forget would be malignancy. And finally, if your patient has any type of bleeding disorder that would predispose them to having abnormal uterine bleeding or vaginal bleeding. Now that we have our critical differential diagnosis, we can now focus on the management strategy for these patients. Our goal is to figure out a disposition plan for this patient within 4 hours of them being bedded in the emergency department. So here we go. Step 1. Find out if the patient is pregnant. You want to find this out as early as possible. Hopefully you work in a highly efficient place and your triage nurse will know just how valuable this information is and will get a urine pregnancy test cooking as soon as the patient checks in. If the patient is pregnant, you will have to go down a completely different pathway with ectopic being highest on the differential. If the patient is not pregnant, then you can move on to step 2, which is don't delay the pelvic exam. What this means is you should go into the exam room with all equipment needed to do a pelvic exam. Get the history, get the physical, and do the pelvic exam. Delaying the pelvic exam will stress you out. You may get a trauma patient that'll destroy your flow, so it's best to just get it done as soon as possible. A couple of notes on the H&P. Make sure you obtain the patient's G's and P's, and also ask them how many times they actually changed their pad, as this will be a marker as to how much they're bleeding. Finally, be sure to ask them anemia questions. Are they having lightheadedness, chest pain, shortness of breath? That'll also clue you in as to how much they are bleeding. When you do the pelvic exam, you really want to look at the external structures and see if there are any lacerations or any lesions that could be causing the bleeding. In the vaginal vault, you'll want to see, again, if there are any lacerations or lesions that you can address. Pay special attention to the cervix to see whether or not there are any bleeding lesions or masses that could explain the vaginal bleeding. And finally, on the bimanual exam, you'll want to assess the uterus and the adnexa to see if there are any masses that could represent a malignancy or something that could explain the abnormal bleeding. When you're doing the exam, hemorrhage can be identified by the inability to clear the vaginal vault of blood. If you can't clear the vault after 4 or 5 Q-tips, you gotta assume the patient's hemorrhaging and get some help. Let's move on to step 3, labs. Of course, you're gonna wanna get a CBC specifically to look at the hemoglobin. You'll wanna get PT, INR, and PTT to see if the patient is at increased risk of bleeding. If the patient is having massive bleeding, you'll wanna type and screen them or potentially cross them if they're hemorrhaging. As stated earlier, the urine pregnancy test will be really important early on in your evaluation of this patient. And that's a good start for the labs, so let's move on to step 4, the treatment. If there's any laceration or bleeding mass, go ahead and address that. Either do a laceration repair or cauterize it if needed. Next, you can give ibuprofen if the patient is having a lot of pain, and the cause of the bleeding is from dysfunctional uterine bleeding. If the patient is mildly anemic, consider giving them iron supplements, and if necessary, initiate a blood transfusion. Medroxyprogesterone can also be given if the patient doesn't have any contraindications, such as needing an endocervical curettage or endometrial biopsy. If the patient is having a massive life-threatening hemorrhage, Then in that case, you want to go ahead and establish 2 large bore IVs, potentially initiate your massive transfusion protocol. Temporize by packing, and finally consider TXA. And that's it for the treatment. So let's move on to step 4, admitting or discharging the patient. Consider admission if the patient meets any of the following. Do they have evidence of active hemorrhage on exam? Again, this would mean that you are unable to clear the vaginal vault of blood. The next thing to consider would be if the patient is at increased risk of life-threatening bleeds. This would be consistent if the patient has thrombocytopenia or if they're on any anticoagulants such as warfarin or any of the new anticoagulants. An obvious admission criteria would be if the patient is hypotensive. Of course, you're not going to want to discharge a patient who comes in bleeding and hypotensive. Also consider admitting if the patient is significantly anemic. Now, we know that most patients can develop severe anemia secondary to vaginal bleeding, but usually it's a slow process that develops over time. And as a result, the patient may not be as sick as their numbers make them appear. Finally, I just want to mention one documentation pearl. In your MDM, it is critical that you document that you cannot rule out malignancy. The patient will need further testing in order to fully rule out any form of malignancy that could be causing the bleed. This is especially important in any woman who's postmenopausal who presents with vaginal bleeding. And that's about it. So hopefully this algorithmic approach to these patients will help you to see them faster in your emergency department. Thanks for watching.